Okay, good morning, everybody. Welcome to the B team. This is day 4 of hepatitis B. Started Wednesday with the hepatitis B cure meeting, so lots going on in this space. So there's going to be new approaches to hepatitis B for 2024 and beyond. So everybody knows there's a huge amount going on. No? Tori, can you turn it up a little bit better? Is that good? Thumbs up? Okay. Good audio test. Okay, so we are going to go through some really hot topics in hepatitis B. Each speaker is going to speak for a little less than 20 minutes, time for 2 questions at the end, and then there'll be a panel discussion. Also, if everybody stays on time, we'll have at least 10 minutes for a panel discussion as well. Come to the mic, say your name, either country or institutional affiliation. Make your question short, if you would, and we'll ask for very short answers. Make sure your phones are silenced, and you have to remember there's an app that gives you CME credit, and these presentations are going to be uploaded once the session concludes, so you'll have access for 30 days. So we're going to start out the day and morning with what's new in hepatitis B biomarkers. Lots going on in this space. We want to understand with Grace Wong's presentation about the significance of these biomarkers, including hepatitis B surface antigen quantification, which is one of my favorite tests in the whole world. She's from the Chinese University of Hong Kong. Grace, so a little bit of technology here. That. And then hit that. Auto disclosures. I think it's working.
Oh, great.
Double check. Currently displaying disclosures. All right, it says wait. So I think you're ready to go.
Oh, great.
Yeah.
Lovely. Okay, thanks. Thanks, Rob, for your kindness. So good morning, ladies and gentlemen. Thanks for having me here. I'm Grace Wong from Hong Kong. So I'm so honored to be the start of this wonderful session talking with this very important topic about surface antigen, which we kind of have been using this for a while, but we are getting more and more understanding on these very important markers. Right, let's get going. Right, perfect. Okay, so maybe I go one step backwards to understand why we need all these kind of happy biomarkers. So because this is a fantastic virus, I would say a very clever virus hanging around inside the individual for decades or even the whole life. So many things will happen over the years. So we need something to help ourselves to understand what is happening, what is going to happen. So during the infections, we need some surrogate endpoints to know whether the patient is responding well to our treatments. But at the end of the day, we would like to know something even more important would be all those clinical endpoints, hard endpoints, and we want to predict the risk as well as to prevent these complications. So the life cycle of this virus is complicated. It's very complex. So let's simply put into 2 major parts. So there would be replicated pathway, which would be represented by some biomarkers like HBDNA, HBRNA. And that's another big part would be about the secretory pathway, some proteins secreted from this virus like surface antigen, and also other antigen I will briefly touch on later on. So in fact, there would be many different kinds of viral particles in the serum, which would be formed by different parts of the proteins, genes, and so on. So in fact, among all these, I would say that most of these viral markers would contain surface antigen, except the naked capsid. So that's why this protein would be hanging around inside the body for decades and very hard to get rid of that. So later on, Nancy will share with us some exciting progress in terms of functional cure, but let's understand these markers a little bit more. So this antigen has been around. We have known it for nearly 6 decades. So we know that, in fact, it is formed by different sizes of the proteins, large, medium, and small. So this is something that we can easily measure qualitatively, positive and negative, but in recent years, we also find the level also matters. And the level also kind of has a complementary role to HBDNA, which we know that is reflected HBV replications, but in fact, surface antigen level tells us even more than that. It's also talking about the transcriptional activity. So what is a kind of marker of the transcriptionally active cccDNA. Another interesting part is, in fact, the level also tells us different things. at different phases of the infections. So in the patients with positive E antigen, usually these patients would be younger in their life. High surface antigen level, in fact, is something good which means that they are kind of still in the old terms, we call it immune tolerant phase, or in newer term, you may call it E antigen positive chronic infection. As well, a very high level of surface antigen in the presence of positive E antigen also means that this patient likely have very minimal liver fibrosis. Or the flip side is, if you encounter a patient with E antigen positive but low surface antigen, is in fact not a good thing. More often, these patients may have some degree of fibrosis because of inflammations. And for E antigen negative, then low surface antigen are definitely a good thing, which means they are inactive, they have lower risk of HCC. So I would say that surface antigen level tells us different things. So in E antigen positive, it's talking about if low level of surface antigen means immune pathology. But in E antigen negative patient, they are talking about immune control. Apart from the natural history, in fact, this marker is also very helpful for us to risk stratify our patient in terms of HCC risk. So we have the landmark review study from Taiwan already set the stage. Viral low HBV level is the very important risk factors of our HCC. But we can further dissect it by using surface antigen level at the same time, especially for the lower end of HBV level. So you can see the bar chart that the green part is talking about those patients already have low HBV to start with, below 2,000, which is usually we may not treat these patients. But you can also see that if we use surface antigen level to further stratify into 3 levels, those with low surface antigen would be at the lowest risk of HCC. So in other way, if those patients still have some surface antigen like more than 1,000, in fact, their risk of HCC is still not negligible. So which means that we should revisit whether this should be one of the treatment indications we should consider. Another thing is about NA withdrawal, post-withdrawal flare. So I think this is a big topic. There have been a lot of arguments over time, whether we should stop, whether stopping and some good flare. Some patients may even achieve functional cure. So I think there have been a lot of good data from the West, from Europe, saying it works. But I have to say it may not work as well as in Asian patients, because you can see that we probably need quite different surface antigen cutoff to really predict whether the patient can achieve S loss after stopping use. So put it simple, Asians need a much lower surface antigen cutoff, probably must be below 100. But in contrast, in fact, in Caucasian patients, probably below 1,000 already work quite well. This is a very new paper published from a group of experts from Guangzhou, our dear friends from Southern Medical University. They found that, in fact, the dynamics of the surface antigen also is a very good marker to predict surface antigen loss. I think that makes sense, because if you see a patient that the surface antigen keep dropping over time, then obviously this patient will get a good chance to lose their surface antigen in their life. So they developed this model called Golden Model. In fact, in this model, they just need one thing. It's just surface antigen. But they look into it longitudinally, and then they derive this model. And you can see the red line. Then these subjects, they have their surface antigen drop over time. And then at the end of the day, their chance of achieving S loss is much, much higher. So it's close to 30%. Or you may put it in a flip side. So if you see a patient that their surface antigen remain almost static over years, then you will know that it's quite unlikely they will lose their surface antigen. Another thing about surface antigen is about the sensitivity of your assay. I have to say that the current assay, 0.05 IU per ml, is already quite good. But if you want to achieve something even better, you can use this ultra-sensitive one. So the detection limit is as low as 0.005 IU per ml, so which is highly sensitive. And from the bar chart, you will appreciate that if someone would be negative to this ultra-sensitive test, 90% of the time they can be maintained as negative over the long period of time. So I think that would be a very helpful tool in the future. Just briefly, these papers were published by our team with my dear colleague, Dr. Terry Yip. I think 2 important messages here. First thing, surface antigen is something very sustained. So most of the patients being spontaneous as treatment-induced, I think it's like 90% years down the line. Another thing is we hope to see that early in our patient's life, because they can achieve surface antigen loss before 50 years old. In fact, their HCC risk would be very, very low. especially among female patients. So just a very quick summary about this very important marker, surface antigen. It's our old friend, but now we understand this marker more. So we know that achieving this is something good. So later on, we'll look forward to Nancy's lectures about what are the new approaches to get functional cure. And another thing is we hope to achieve this early, that hopefully can further minimize the risk of complication HCC. And we can also use this tool to further risk stratify our patients, their HCC risk, which I think can be also one of the treatment criteria we can consider in our upcoming treatment guidelines. So I would say that achieving surface antigen loss earlier the better. So now I just want to very quickly touch on all the markers because we often use all these markers together. So a quick word on cccDNA. You know this is something only measurable in liver, so we need liver tissue to measure that. But there are also very good data showing that in fact surface antigen level also kind of reflecting the burden of a cccDNA inside the liver. And you saw this a while ago, but this time I want to focus on another biomarker. It's called core-related antigen, or another term you can call it CRAC. So it is a collective measurement for a few things. So the E antigen, the P22 core, as well as the core protein. So the name is called core-related protein. So you will imagine that among patients with positive E antigen, then the level must be much higher than those with E antigen negative. So these markers has been around for a while, and which have quite a bunch of studies, especially from Japan, showing that in fact this is very helpful for us to predict some kind of surrogate endpoint. So the table summarizes a few studies talking about like core-related antigen can be very helpful to predict surface antigen loss. So I would think among all these, E antigen zero conversion is definitely very helpful because you can see a very significant drop of core-related antigen over time. How about predicting S loss? I think there's also some data. So like in this curve showing that whether we can use either surface antigen level, either core-related antigen level, or put them together. And at the end of the day, you find that using both markers together can further improve the predictions of S loss after PET interferon therapy. So I think this is one approach we consider to use these two markers together. And not just treatment endpoint. In fact, core-related antigen would be also helpful to predict some heart outcome like HCC, but mostly in E antigen negative patients. Because you can imagine that E antigen positive patient, most part of the core-related antigen will be E antigen itself. So in fact, we performed this study a while ago showing that among E antigen negative patients, you can further use the core-related antigen level to stratify the HCC risk, which can design the HCC surveillance for our patients. And I just want to briefly mention that these two markers are helpful, but each of them have their issues. Like surface antigen level, in fact, at this moment, we can really differentiate whether it comes from integrated H3 DNA or is the existence of a cccDNA. So this is still a thing we probably need to sort out when we plan ahead our HBV cure regimen. And also, as I briefly mentioned, ultrasensitive tests probably would work better to really predict a sustained S loss. For core-related antigen, I think the current issue is the sensitivity of the assay is still suboptimal. It's usually still 2.9 logs, which is close to 1,000 units per mil, which is not that helpful at some setting. So whether it is also be helpful to predict whether the patient can achieve a life functional cure, we still need more data on that. So finally, just touch on HBV RNA. This is another biomarker that can be measured in our serum. So I wish to share with you this very new papers. Very hot from the oven is from Hepatitis B Research Network. It's a group of very active researchers in North America. In fact, I have to thank Dr. Noratora for sharing with me these very new papers, this very informative graphical abstract, showing, in fact, a very unique cohort of patients. They received a few years of tenofovir. Some of them also treated with PET interferon. So they wish to understand any predictors about sustained partial cure, which means that post-treatment they remain very inactive, low DNA, and so on. So here they put together two biomarkers, HBV RNA, together with the surface antigen. So if you can achieve undetectable HBV RNA, which in fact the detection limit is quite sensitive, I would say, is 1.65 logs, which means it's 44 U per ml is sensitive enough, together with low surface antigens at 100. So in fact, this is a very good predictor to predict like sustained partial cure as well as low risk of post-treatment flare. So I think definitely these markers will be very helpful for us to select our patients who will be responding well to our upcoming HBV cure regimens. So to sum up, this simple table just put together all the markers. I would say that surface antigen level is still something very helpful that for us to understand the natural history of the patients, where they would be at risk of having complications, as well whether they can achieve some treatment endpoints. And at the end of the day, we wish to see this level would be as low as possible, hopefully can become undetectable, then the patient will achieve functional cure. And put together with other viral markers, especially the core antigen, HBRNA level, also would be helpful for us to predict the stop NA treatment. So with that, I thank you very much for your question, listening. Okay, thank you.
Thank you, Grace. Say just for a second. So this is exemplary, finished before her time. We have time for 2 questions, and while people are coming to the mic, I just want to ask you, should every patient get quantitative S antigen baseline and then annually? Is that really now the standard?
I would say it may not be the standard, but I love to do that. I'm doing more and more surface antigen level for my patients now, mostly because I wish to see whether they would be suitable with some of the treatment program. But I think that in the upcoming treatment guideline, that will be part of it. May not be a mandatory measurement, but if you have the assay, it would be nice to know, because that would be very helpful to see what kind of cure regimen the patient will respond to. Yeah.
In the US, Mayo Clinic offers commercially, clinically, the correlated antigen, the quantitative assay. Should I be ordering that on my patients now?
Again, it would be nice to have. Also, I measure it for some of my patients, either to predict whether they will have HCC, or like if you wish to stop them from nukes for whatever reason, I think this is also helpful to predict any post-withdrawal flare.
Great, thank you.
Thanks.
One.
Robert, nice to meet you. Good talk. The question for you, are talking about the Asian with surface antigen less than 100. What duration do you monitor the surface antigen? Every 6 months? Because from my personal experience, I'm from Los Angeles, I do every 6 months for those we don't need to treat. So the cutoff of 200 can have the prediction is low. And second question for you is a genotype related to BOC.
Oh, okay. Wow, great questions. Okay, so if those are, if we stop the treatment because of the low surface antigen, usually I will closely monitor the ALT HBV more. But for surface antigen, at least I don't think we have to monitor it very frequently. Yeah, because what you worry a bit more is about post-treatment flare, which Harry will have a lot of experience on that. But for surface antigen, probably I may not monitor it that frequent. Maybe, I think every 6 months is a bit too frequent to me. But for ALT, HBV, I would monitor it every few weeks or every few months during the first year. If it remains stable, then we can space out to every 6 months. Yeah.
Yeah, so interesting. You say less than 100. Yeah. So you follow up every 6 months. So 100, what that number, magical number comes from? Instead of 200, the surface antigen. Yeah.
Surface antigen.
Yeah.
Oh, okay.
Quantitative.
But if 200, usually surface antigen may not change that rapidly. So if it drops very slowly over time. And for genotype, the second question is yes. So I would say that at least in my region is mainly B and C, genotype B and C. And the surface, I don't think there's a huge difference there. But I think the difference is mainly for young patients, genotype C patients usually have delayed E antigen seroclearance. That's what we observe. But if they already kind of reach like post E0 conversion, their level would be quite comparable. Yeah.
So the last one.
Wait, we've got a little bit more time. Oh, Harry, hold for the end. Dr. Janssen.
Yes, thank you. Hey, Harry.
Thank you very much, Grace. Wonderful talk, really. First of all, I would like to stress the importance of quantitative S antigen measurement around the globe, also here in the US. So I completely agree with Bob on that. The question I had is you mentioned basically that S loss is a pretty definite, sustainable endpoint, which it has been thus far. Yet with the new trials that we're doing trying to cure hepatitis B, we do tend to see many more S0 reversions, right? So what is your perspective on that as using S antigen loss as an endpoint?
Right. May I confirm you mean that surface antigen loss because of the HBQ regimen, or just by new?
Well, just no, with the new agents basically trying to cure hepatitis B in the trials that we're currently doing, we see a pretty high S loss rate. Yet off treatment, we do tend to see more S0 reversions, and some people will still make it to the finish line likely, but it's not as sustainable with PEG interfering with nukes or in the natural history.
Yeah, very true. So probably I will leave these questions to Nancy lectures. I think she will tell us more. But I have to say that for the current HBV cure regimen, I think the other big part is how to maintain the functional cure sustain, which is very challenging because we more often to see they may drop the surface antigen nicely, even undetectable, but quite many of them will have relapse if we stop all the treatment. So I think we need some kind of immune modulation to maintain this part.
Or another endpoint like partial cure, right? That we don't know. To have a little bit of S antigen still around from the integrated DNA, that might be an option.
Yeah, I agree. Yeah, thank you.
Thank you, Grace. We'll have more time for Q&A at the end. Everybody's going on time so far. Thank you very much.
Thank you so much. Thank you.
Okay, Calvin Pan's our next presenter. He's a professor of medicine at NYU, New York City, world leader in preventing mother-to-child transmission, and we're going to get more updates. Calvin, welcome.
Oh, thank you. Could you help me out to get this? Thank you so much for your introduction, and I'd like to thank AASLD for inviting me this presentation. So,
No files have been uploaded. Uh-oh.
I just uploaded yesterday.
Go check that one. Yeah, double click. It's ready. Yeah, we're clicking on the second one.
Yeah, it's not moving.
Oh,
And then you have to hit start. Oh, okay. So here's my disclosure, and just 1 second. Okay, so my topic is provide you the updates on the prevention of vertical transmission, a key strategy for achieving WHO goal for hepatitis B elimination. So let's briefly review what is the elimination plan. In 2016, WHO issued a plan for global elimination of viral hepatitis, focused on 3 targets. One is 90% reduction in new infection, and 80% of eligible patients should receive antiviral therapy. And lastly, we should have a 65% reduction in hepatitis B related mortalities. However, in order to accelerate the elimination, in 2016, this plan has been updated with the same targets and same goal. However, shift a little bit on the strategic priorities. For example, universal health coverage now will focus more on the integrated people-centered care and focusing on more innovation, invention of the new therapy, and hopefully to get the solution for hepatitis B cured. Now with that, let's take a look at the current snapshot on the global prevalence, cascade of care, and prophylactic coverage for hepatitis B. Per area using the Markov model, estimate that about 258 million patients currently infected globally, and among them, 36 million under the care have been diagnosed, but unfortunately, only 6.8 million people receive antiviral therapy. More interestingly, if you look at children at the age of 5 or younger, you still have new infection, 5.6 million, that come out with every year, perhaps 1 million children will have mother-to-child transmission and become chronically infected. Now, why is that? So the paper actually did the survey and find out that there are 3 major reasons. Number 1, poor availability of HBV. Only 4% of those children who are eligible to receive HBV eventually got it. And poor coverage and antiviral treatment, to a big surprise, only 3% of those mothers with high viral load, we're talking about more than 200,000 IU, per ml could receive antiviral treatment during pregnancy. Well, of course, there's still issues with the first dose of HBV vaccine. So with that in mind, how we put those numbers together in the context of WHO elimination plan. So the elimination plan focuses on 4 key elements: prevention, screening linkage to care, expand the treatment, and look for cure therapy. Let's just start with the disease burden. If you look at about 258 million individual disease burden, the contribution for new infection, actually majority of those patients are mother-to-child transmission. You're talking about by 2030, you accumulate about 5 million to 7 million new infection. But if you look at the treatment, because in the setting of very limited efficacy of antiviral therapy, you're talking about 5% surface antigen loss on new treatment for 5 years. So even you expand, the guideline expand the treatment for every patient. Now diagnosis with hepatitis B, you calculate that 36 million, you come up in the next 5 years, you can only get 1.8 million functional cure. So in the current limited efficacy of antiviral therapy, I think the prevention of mother-to-child transmission probably give you the better hand on reducing the disease burden. So that leads to my second part. Let's get some updates on the strategy for preventing mother-to-child transmission. I'll cover the vaccine, HBV issues, how they expand the access to antiviral therapy, and finally I'll touch upon on the HBV-free regimen and try to tackle the challenge of only 4% of infants receive HBV. Well, you're all familiar with vaccine. For the last 200 years and more, collectively, all these vaccines improve immune functions, every year saving about 4 million lives. But what I want to point out is in 1981, we have a hepatitis B vaccine. The vaccine compared to the others have somewhat different actions when you put it to the newborn babies, because most other vaccines will be given to the individual who have no disease to prevent the disease, like primary prophylaxis. But hepatitis B vaccine, actually, if you're talking about infants from E antigen positive mothers, and 80% of chance they have viremia already. So the HBV vaccine actually serves as a therapeutic intervention and try to eliminate the viremia and prevent the infection. It's not quite similar to those other vaccines given to the patients or individuals who have not been exposed to the pathogen. So with that, you would expect that if you're using it as a treatment modalities, and you may expect different treatment effect, depends on the exposure and the concentration of the pathogen. In E antigen positive patients, if you look at the red color column, approximately 78% of those infants without the vaccine, and they will develop chronic infection. That implies they have viremia at birth. But the effect for preventing chronic infection still suboptimal in E antigen positive mothers. You can still see about 7% breakthrough for the vaccine plus HBV. However, in a lower level of exposure, like E antigen negative mothers, those infants born from those E antigen negative mothers perhaps have much lower viremia exposure, and you could prevent 100% infection. So the vaccine actually works well. This is the data from Taiwan. In the public houses setting, you can show at least 10 times reduction after you use a universal vaccine to provide protection or treat those babies with transient viremia. Now for E antigen negative mothers, if you give their infants vaccine versus vaccine plus HBV, and the meta-analysis actually showed that vaccine is good enough to protect the infants from E antigen negative mothers, because those mothers often have a typical viremia level less than 20,000 IU. I want you to remember that, and later on we'll discuss why we can use HBV-free regimen. So with that, but for E antigen positive, that's different story. And those mothers with high level viremia, particularly 6 log copy or 200 IU per ml, higher than that level actually translated to a high exposure and transient viremia for those babies, and they will fail combined immunoprophylaxis with vaccines and HBV. The higher the viral load, the chances you have a higher risk of transmission. So can we enhance the vaccine's efficacy by giving them earlier in this high-risk group? If you look at the meta-analysis just recently published, mainly look at, in the randomized controlled trial cohort studies, those babies without antiviral treatment, but receive a vaccine and HBV. They were all born from mothers with high level of viremia, and showed that 3 subgroup analysis, whether the baby received vaccine HBV within 6 hours versus the window of 7 to 12, or versus 13 to 24. And meta-analysis showed that there was no indication showing the early vaccine can solve this problem if you have a high level of exposure. So in 2016, the first randomized controlled trial to tenofovir prevention prevent mother-to-child transmission have been published, and since then, you're quite familiar with every guideline and propose that we should use antiviral treatment in those mothers with high level of viremia. In this randomized controlled trial, 200 mothers randomized to either use tenofovir in the 3rd trimester after gestational week of 28 to 30 versus no antiviral treatment, and show that at least it's a significant reduction, 13% reduction for ITT analysis, and there was no infant got infected in the per protocol analysis. But this approach has faced some criticism because there was a concern on the baby's bone mineral contents in newborns from HIV study by NIH, and showing that there were some signals to tenofovir exposure in HIV mothers to the baby and caused lower bone density measurements in those newborns. However, hepatitis B is a different story because you only use it for a very short period of time, about 12 weeks, versus HIV, you will have to use that for the full duration of pregnancy. So with that concern, the cohort that you just seen have been followed up for 4 years. This is the update data, and showing that mothers who treated with TDF for 12 weeks, their babies after 4-year follow-up, there was no difference in intellectual developments, including physical developments. There were some p-value there in comparison some of the variant, but mainly showing that TDF arms actually have a better score. So not only that, just early this year, there's a large real-world study looking at the data of efficacy and safety in China, enrolled more than 30,000 mothers with high level of viremia, and they have 2 stages of the study data, first stage and second stage, and also compare the compliance mothers versus the non-compliance mother for their infant outcomes. And this is study basically showing it's very safe to use tenofovir during 3rd trimester for the prevention of HBV transmission. And also, the transmission rate is very low. If you use it properly, compliant patients, it's less than 0.2%, somewhere 0.2 to 0.3%. So this is data further ensure that we should use tenofovir to prevent mother-to-child transmission. Now, how about expanding the access to antiviral? We know that now in HIV war, we're replacing TDF with TAF. So in order to look into the issue, can we use TAF to prevent mother-to-child transmission? And in China, only in China now, there's several publications, including cohort studies and randomized control trial. There was a small one randomized control trial, but all the others had to have comparison between TAF and TDF. The efficacy is very encouraging because there is zero infection in all these studies for both arms, and the safety, the short-term safety signal hasn't been disappointed. They are equally effective and safe based on this meta-analysis. Now, lastly, I want to tackle on the issue of HBV. We know that only 4% of those infants globally receive HBV. Without HBV, only vaccine, even you give tiny matter, the infection rate for high-level viremia mother can transmit the disease about 25% of time. So in order to tackle this issue or overcome this challenge, just 2 days ago, this is a large randomized control trial for HBV-free strategy population, JAMA. This study enrolled 280 patients with high level of viremia, more than 200,000 IU, stratified them to treatment group. That's the experiment group with tenofovir, starting at gestational week 16. So they totally receive approximately about 24 weeks treatment, which is the current standard of care. You will start in TDF at gestational week 28, only about 12 weeks treatment. Then the experimental group would not receive any HBV. So both groups get the vaccine, but the control group, the standard care group, will get the HBV and the vaccine. The final outcome would be 28 weeks mother-to-child transmission rate. This is a non-inferior trial. The margin set for 3% that's deprived from the previous study in TDF and Namivudin. And within that window, you can see the ITT analysis showing there was less than 1%, exactly to be exact, 0.76% of infection in the experimental group. That means without HBV. However, in per protocol analysis, there was no infection in both arms. So both 90% CI, the upper limit of 90% CI within the 3% margin, indicate that both therapies equally effective, as non-inferior. So suggests that we should consider to give HBV-free regimen in the area that you don't have any HBV available. But more interestingly, if you look at 24 weeks treatment at the bottom of the table, 24 weeks treatment of TDF actually can be more successful to get down the viremia level below 20,000, which is quite similar to the typical hepatitis B E antigen negative mothers, their typical level. So we show the data that you don't need HBV for that population. In contrast, if you only offer those patients 12-week treatment, you will have only half of them can achieve that goal. So a short-term treatment may not be feasible, even though this is not a study trying to compare which duration of treatment. The safety is optimal. So I have to caution you because the safety is a secondary analysis. It's not powered by this study, but at least just a ballpark number, the congenital malformation, they're pretty much comparable. So not only the randomized control trial, but we also have the real world data, but this data is a little bit challenged and limited. This is the Cambodian study of real world, enroll patients for TDF treatment without HBV versus just giving the vaccine. So the control group is not high level viremic patients, but E antigen negative patients. The E antigen positive patients will get TDF. But even in that TDF treatment arm, there's still some patients, about 20% E antigen negative, potentially diluted the transmission rate. So what we learned from this study is that it's safe to give TDF, and also HBV-free regimen. They have some infection because only treat patients about 12 to 14 weeks. And most infection, those 4 patients are from a short duration of treatment. So from the other angle, you can look at a short-term treatment may be more challenging if you want to guarantee the patient have less chance of infected. So lastly, I just want to highlight the most recent published WHO guideline in terms of how to expand the coverage of antiviral treatment. And now if you have the ability to measure HBV DNA, that's fine. You can use DNA, surface antigen level, or year antigen status to determine whether this patient put on antiviral. But the WHO guideline take one step forward in saying that you can offer any antiviral treatment, only need to test surface antigen. So with that, I would summarize my presentation. We need to identify high-risk mothers, perhaps through the point-of-care testing. And mothers, you can use TDF or TDF, equally effective, to prevent mother-to-child transmission. And HBV regimen now have a great evidence to prove that it works. So with the implementation of all these methods, and hopefully we can prevent more than 6 million patients infection in the next 5 years. I thank you for your attention.
Thank you, Calvin. We have time for one question. Any hot topics? Dr. Lim, you going? Going the other way. All right, Paul.
Calvin, very nice. Was there any attempt made to limit the time interval when the infant received normal hepatitis B vaccine? Because there's been previous data suggesting that if they get it within 4 to 6 hours, it's protective, which is a problem for us in the U.S. on the weekend.
Yeah, I thank you for that great comment. As I show in the presentation that we cannot tear down between 1 to 6, but as a group, 1 to 6 versus 6 to 12, 12 to 14, there was no difference. I think not only the data suggests that the early vaccination may not work well, but also the implementation challenge. It's hardly to get those babies get vaccinated within a few hours, particularly in the other part of the world, not the U.S. And what I believe, what might work or may not work is, I think in order for transient viremia to settle down in the liver, it needs about 24 hours. Any time before that, you get the vaccine, you initiate so-called therapeutic vaccine and stimulate, you can clear that. So that's why you don't see that. But of course, I don't have a solid proof unless we can tag the virus with isotopes and see where they go. Thank you.
Very short question. Sangeet.
That's a very nice talk, Calvin. In the light of the new WHO guidelines, are we going to stop tenofovir in these pregnant mothers, or you might as well put them on lifelong therapy?
I didn't get that.
So is it lifelong, or do you stop treatment at termination?
I think that's a great debate in many guidelines. I'm not going to elaborate that. I think more trend towards, put them on and leave them on. Thank you.
All right, thank you. That's fantastic. All right, next presentation. Nancy Rowe. Let's see if I can get this to start this time. That's good? Okay. Nancy's a hepatologist at Rush University Medical Center in Chicago, and I just want to put in a couple of little plugs. Hepatitis B Foundation has a website with new drugs on it, and I've also created in the last month a 13-page document with Dr. Bhuti for our MTE. And if you want to go to my website, robertgish.com, you can download a 13-page document of what I think is every drug in development right now, name, company, mechanism, and what phase it's in. And I think it's quite current, but we're going to validate this with Nancy. Thank you.
I am going to defer because in 20 minutes, with a lot of different agents and things on the horizon, I'm sure that Dr. Gish's document is more comprehensive. So disclosures. Not knowing that we have what kind of audience, I wanted to make sure that in our blended environment, I did at least set the stage before talking. Often I find that, especially if I sit into a lecture where I don't have a lot of experience, I'm lost on the first slide. So our goal of therapy, irrespective of what therapy it is actually survival and quality of life, along with maternal childhood transmission. And that is a really important focus because although we are talking about functional cure, you want to make sure that that functional cure translates to the endpoint, which reflects actual survival. And so our optimal endpoint is going to be hepatitis B surface antigen loss, and I'll talk a little bit about that. But we often use a surrogate of hepatitis B DNA suppression as our main endpoint, as that seems to also translate to survival benefit, even if not perfect. We're all very aware of the hepatitis B life cycle, and as we go through this talk, that there are targets really across every aspect of the hepatitis B life cycle, but it's really the Achilles heel that has been integrated in the CCC DNA. There are other Achilles heel, but this is really one of the problems when we talk about elimination or functional cure or sterilizing cure. It's how to get rid of the type of hepatitis B particles that are very protected and difficult to access. There is more than one hepatitis B cure definition, and the authors of these excellent documents are in this audience. Sterilizing cure is really ideal, but functional cure is what we would describe as sustained. So after 24 weeks of therapy, hepatitis B surface antigen loss with or without serial conversion to surface antibody, and undetectable E antigen, and hepatitis B DNA that is undetectable after a finite course of therapy, which is implied because that's 24 weeks after treatment. There are other things like partial cure, but we're going to concentrate on this functional cure. Grace already gave a great talk about our biomarkers, but it's important to know as our patient transitions through the natural course of hepatitis B that there are changes. So early in infection, our hepatitis B E antigen positive patients, the majority of their surface antigen actually is derived from CCC DNA. As a person becomes later, and this is important when we're looking at how we recruit into trials, how we identify patients that are appropriate for these treatment strategies, your E antigen negative patients, although some of the surface antigen does still come from CCC DNA, a large amount of it is actually now coming from integrated hepatitis B DNA. And I'm not going to go through a lot of this, but this is where the core-related antigen and other biomarkers might help in these curative strategies. Hepatitis miracles seem to be derived by a 6-month marker, and I think that this has legacy. When we lose something in an NA platform, and we know that it's durable after 6 months, it seems to have long-term durability, whether we look at that as spontaneous, pegylated interferon, or I already implied, nucleic acid therapy, but this may not be an appropriate endpoint as we look at some of our other mechanisms. If the mechanism of action is very long, we might have to go beyond a 6-month post-treatment endpoint, or know that we have to have a strategy that's going to do something else to help us make that durable. That does not mean that we shouldn't aim for 6 months. It just means that as we look at our studies and we're looking at long-term outcomes, it would not surprise many of us in the audience to find that there are relapses after that 6-month point, depending on the mechanism of action. Now, just to make sure that we understand why surface antigen is so important, or surface antigen loss, this is just a little bit of review of which Grace has already covered, that spontaneous surface antigen loss leads to excellent prognosis. And this is a large study looking at liver cancer rates and cirrhosis rates in people with spontaneous loss surface antigen, showing that that surface antigen loss translates to outcome. This is very similar data, but now in surface antigen loss with nucleic acid therapy, and you can see here that it is far superior to have surface antigen seroclearance compared to complete virologic suppression when you're looking at liver cancer risk. And so it really, we still want hepatitis B DNA suppression, but it is important to know that our risk is further downsized by surface antigen loss. But knowing the tools that we have currently, whether it is an E antigen or E antibody negative positive patient, we are very good at suppressing hepatitis B DNA. We are not particularly good at surface antigen loss, and that also includes pegylated interferon. And I'm going to just skip over this because it's talking a little bit about prognostic roles of quantitative hepatitis B surface antigen. I think the most important thing is in the US, we have to start measuring this. This was reflected in the Q&A and Dr. Gish's reminder, how often should we be doing this? Like, we should
be doing it. I think in the US we've had tools that have lagged behind, making this a little bit harder for us to order. But quantitative surface antigen has prognostic value both at the end of treatment, on treatment, and at baseline. So we are going to start to need to use this tool, especially as we go towards functional cure. It's also really important to know what we're doing, how much better it is, starting with where we're at right now. So you have to know your starting point in order to predict what you need to do in the future. So with our current treatments, only about 2 to 5% lose surface antigen after about 10 years, but I'm going to reiterate what has already been talked about. That's only for the total population. You can look at subsets of the patients that are on treatment and find that there are individuals that have better expectations than that low rate of hepatitis B surface antigen seroclearance. We know that baseline factors such as E antigen, lower DNA, and that quantitative surface antigen can be predictive, but Grace already went through this, Dr. Wong went through this in the RETRACT-B study. There is significant prognostic implications by quantitative hepatitis B surface antigen with different levels by ethnicity that allow you to have a much stronger ability to predict who might lose surface antigen if you stop their NA. Up to 41% in a Caucasian population with a hepatitis B quantitative surface antigen less than 1,000, and a third in less than 100 in an Asian population. That doesn't mean that this is the majority of our patients, but it does mean that we do have tools already to lead to functional cure in a population that we're already treating. When we turn now to 48 weeks of pegylated interferon, again, knowing where our historic legacy starts, also important as we're adding PEG to many of our direct-acting antivirals for hepatitis B, up to a quarter can achieve a hepatitis B DNA suppression, but small amounts actually lose surface antigen after several years. But you can look at futility rules and you can seem to guess who might do better than others, but they're complicated. So you have things that start at baseline, you have on-treatment rules, but to try to apply these in a large real-world population is going to be very convoluted. This is looking at a study that the new SWITCH study, where patients who were inadequately suppressed with an NA then were switched to pegylated interferon, and you can again see prognostic rules or futility rules, depending on if you're a cup half empty or a cup half full, and that there are patients who drop by 12 weeks, but definitely by 24, who you can see lose surface antigen and might help you limit pegylated interferon exposure, but still allow a subset of individuals to achieve functional cure with the current tools in our toolbox. But that's not what you wanted me to talk about. You wanted me to talk about the future, and I'm going to say that we don't have a perfect answer, but we have a lot of great ingredients, right? So you may have, like one of the Iron Chef shows, you might have an entire closet full of amazing things, but if you stick them all together, it might not taste very good. And so what we need to learn as we go through the next several years is how to safely and effectively combine the tools and the future tools that we have so that we end up with something that allows the majority of our patients functional cure. And you can see here that we have agents that work on replication, agents that work on surface antigen or E antigen reduction, and then immune modulation, which is also going to be very important. And you may not need to combine them all, but we might find that we need to take one from each class or some degree of that. The life cycle, the hepatitis B life cycle, again, has targets at every aspect. This is a very nice New England Journal graphic that I'm going to try to recycle as I go through this. And the authors of this paper are in the audience, but showing that really there is drug development across every aspect of hepatitis B, as well as the immune modulatory effects. So starting with entry, if you block entry, then you can prevent infection, and you can also possibly improve your immune modulating effects. So our entry blockers, because they decrease surface antigen, they might improve your B cell and T cell responses, and so they both are potentially direct-acting antivirals as well as immune modulators. They, however, are not particularly effective by themselves. We now can move to our hepatitis B core protein targeting antivirals. There's an entire workshop on what we should call these. I'm going to call them capsid assembly modulators. Not that that was the end result of that workshop, knowing that there are multiple terms for things that kind of fall into the same class. These are improving as all of our drugs. I walked over with Dr. Agarwal, who was reminding me that this is the generation of telaprevir and boceprevir for hepatitis B, or maybe you can even argue that we're a little bit before that. But our first generation CAMs are good at interfering with capsid formation, generating either empty or funny looking packaging, which then impacts the protein formation in pgRNA, as well as DNA replication. But our second generation CAMs actually start to block disassembly, which affects cccDNA establishment, as well as intracellular recycling, which affects CCC replenishment. And so they are already improving. It's important to note that these are oral. They are not completely resistance-free, but they are effective against hepatitis B resistant variants from NAs. They have an additive effect when you combine them with a nucleic acid and decrease hepatitis B DNA, pregenomic RNA levels, but they have minimal effect by themselves on surface antigen levels, or E antigen, in the first generation. When you discontinue them, your virus tends to come back, and I give you the reference here, and you might have a flare. Most of these are safe, but would you try to avoid flares if possible? When you combine them, this is looking at the CAM with siRNA, J&J. They did show that there was a smaller decrease in surface antigen levels compared to an siRNA and an NA, suggesting in this study that there was a possible antagonistic effect. This means that, again, you have to be careful with how you combine things. Sometimes it sounds like it's a good idea, but the outcome may not be what you wish, which is okay. It's still a learning experience, and it's important as we learn. This is looking now at a second generation CAM, looking at extended treatment of the Alagos plus or minus entecavir. And we don't have the final results here. This is 72 weeks. This was presented at the European Liver Congress. Hopefully we'll get more through AASLD and then EASL next year. But you can see on the right hand of this graphic that hepatitis B DNA levels are incredibly low with or without entecavir, suggesting that this is a very good viral suppression. When you look at the graphics on the side, you can see that surface antigen and E antigen decline. Surface antibody seems to go up, but there was a message that if you had a low baseline surface antigen, you might have had less response, and that could be reflected of the integrated DNA. Remember, our second generation CAMs might have more effect on your CCC establishment and replenishment, and that's good, but that's also where you have these other tools that might help us know what is residual behind. Moving now to our siRNAs, or RNA interference. This includes siRNAs as well as our antisense oligonucleotides, or ASOs. These target hepatitis B messenger RNA, so they lower viral antigen production. They inhibit hepatitis B replication. So remember, they're really good at lowering some things, but not necessarily all things. Your siRNAs are going to be short, double-stranded RNAs. These do require a carrier vehicle for uptake. Your ASOs are single-stranded DNAs, or RNAs. They do not require that carrier, but they do require mechanisms within the virus. But you can target them towards pre-mRNAs, which seems to then decrease some of the off-target effects. BEPI is, something that we've been talking a lot about. This is the New England publication on this, monotherapy, looking at a couple of different doses and durations. And you can see that on the right-hand side, it doesn't sound, hugely impactful in that there was 9 to 10% functional cure in the BClear study, but this is still functional cure. And if you look more carefully at the individuals that were recruited into this, hepatitis B, quantitative hepatitis B at baseline is predictive. And so if you identify your patients appropriately, you're going to get a much better response than that 9 to 10%. We also know in the phase 2b Together study, if you add pegylated interferon, you don't necessarily get more quantitative surface antigen loss, but you get less relapse. And so if you select your patients well, you give an immune modulator along with this, then you're going to have more durable response in the population that loses the surface antigen. All right. If we turn to the siRNAs, this is just one not particularly up-to-date graphic showing that there are lots of siRNAs in development. These do lead to a 2 to 3 log hepatitis B surface antigen decline after 3 to 4 doses, which does last for 6 to 9 months. Remember, 6 months is our definition of functional cure, but if you're using something that might have durability beyond that, it's important to watch the patients more than just 6 months off therapy. The surface antigen does plateau around 16 to 20 weeks, and despite ongoing dosing. So remember that we can't just expect more or longer durations to do better. And functional cure is not reported in most of these studies, so that we have some. But we're looking still at the future to find out where these are going. Interferon-containing regimens have shown the best long-term data, suggesting that immune modulation is going to be an important aspect. I must have a slide hidden. I was going to give a big shout out to Arbutus because there's a 50% functional cure in their arm that received siRNA and pegylated interferon in the group that had a quantitative baseline surface antigen of less than 1,000. So not everyone, but if you pick your patient well, you can expect to have a durable, good outcome. Now, this is looking at combination therapy, right? We know that we're going to require more than one tool, and not everyone wants to use pegylated interferon as that tool. So when you looked at the J&J siRNA with CAM in the REEF-2 study, although there was significant antiviral effects, the hepatitis B surface antigen declined significantly. Hepatitis B DNA declined. The study did not show any functional cure, which is the primary endpoint. That isn't disheartening. It just means it's a starting point, and we know that we're going to have to do other things to modify either this therapy or similar ingredients to add to functional cure across the pipeline. Now, nucleic acid polymers, or NAPs, this has had a lot of splash. Unfortunately, not a lot of follow-up, as I think this agent is still making presentations, but not necessarily recruiting new patients outside of compassionate use. But our NAPs actually block the release of subviral particles from hepatocytes. So looking at these two rep NAPs in combination with pegylated interferon after a lead-in of NA therapy, they did see hepatitis B surface antigen loss in about 60%, which persisted in about a third after 6 months. But if you can see these little messy graphics, there are lots of ALT flares, which might be a good flare, but it's a little nerve-wracking when you're treating the patient in front of you to see these ALT levels go up, some of which went into the thousands. But this truly looked at functional cure. They stopped everything, and you can see that about a third were able to have a functional cure at the end. Now I want to turn to things that are, sound fantastical. This is gene editing, and I'm going to lump, even though it's probably not appropriate, since I'm not a virologist, I'm allowed to, just a hepatologist, epigenetic editing. So we can remove or tag things for removal. And this is really exciting. And it sounds like it's super, futuristic. However, this technology does already exist in other disease states. And so you can see this nifty little graphic looking at the CRISPR-Cas13b technology, which is targeting in this study, hepatitis B RNAs to degrade. There was also a CRISPR-Cas9 that looked at CCC DNA, and this is in vitro or mouse model. But you can see on the left-hand bottom that the red is a significant decrease in pregenomic RNA and core messenger RNA, and then total RNA in the groups that were treated. And then of the little mice, there's a huge decrease in hepatitis B surface antigen levels, which is what you would expect. And I am being told to wrap up, which is good because I only have a couple more slides. This is also looking at the ARCUS gene editing, which is double-stranded DNA editing, removing both integrated as well as CCC DNA. Our immune strategies are all over the place. Remember, monoclonal antibodies also are included here, and I'm going to do a shout out to the Virion, which looks at a triple mechanism of gene editing that amplifies T-cell response, as well as T-cell repair and B-cell. And this is, again, very super futuristic immune modulation. Just reminding us, vaccination is going to prevent this. So as smart as these sound, you want to vaccinate the people in front of you. Sorry to be over.
Thank you, Nancy. Okay, we're going to wrap this up with Dr. Robert Wong from the Stanford VA Palo Alto. And let's see if we can get this back. And let's go to you. Start. I think I got it this time down. Robert, who I've worked with for over the last 1.5 decades, is going to be talking about something that we at the Hepatitis B Foundation have been advocating for strongly, which is a test all, vaccinate all, treat all approach. So I want to thank Sherry Cohen, who's somewhere here in the back, and all the staff at the Hepatitis B Foundation. Robert, take us.
Great. Thank you. Thanks, Bob and AASLD, for the invitation. So I'm going to try to wrap up the session by trying to meld together what a little bit of everyone said. And the task was to explain how to navigate the test all, vaccinate all, and potentially treat all approach for providers. So the objectives will be, first, to really understand what that means. Where we are with policy and guidelines, and what are the gaps and challenges to implement that type of mindset in approaching the care for hepatitis B patients. We're going to talk about policy changes, US-centric, that we have had some improvements in evolving this cascade. And then, as I mentioned, to understand the challenges and how we implement that. First, I think it's important to really understand how complex the hepatitis B cascade is. We're going to talk in just 20 minutes in how to navigate this in terms of screening, vaccinating, and treating. But as you can see here along this cascade, it's not that simple. And hopefully one of the main messages that I'll try to drive home today is that the hepatitis B cascade is very complex, and implementing these types of recommendations are not as easy as it seems. So first, we're going to talk a little bit about the early stage. What are the new recommendations and implementation recommendations for screening and vaccination? I'll start with this. Dr. Pan already reviewed some of these epi data, but these are global epi data updated from the Polaris group. And the two take-home key points here you can see are gaps in diagnosis. So if you look at the first and the third bars, you see there's a huge gap in diagnosis. The second key point to highlight is if you look at the second and the fourth bar, there's a big gap in treatment. Even if we think about eligibility, which we'll talk a little bit more later, there remains a big gap in those that are actually treated. What about in the US? These are data from our group that we updated. US probably estimates on around 2, maybe 2.4, 2.5 million. But we see the same gaps in the US. So I highlighted 3 studies that have been published in the past few years that really highlight gaps in testing. The REACH US cohort, which is about 54,000 ethnic minority populations. Also data from the Kaiser Hawaii database, about 93,000 Asian Pacific Islanders. And then published just about 4 years ago using US claims and NHANES data. You can see that less than 20% of individuals with chronic hepatitis B were accurately diagnosed. What are the reasons for this? I think the reasons for gaps in diagnosis are very complex. There's some data that suggests that lack of awareness. These are 2 graphs I took from 2 studies published. One is a safety net center study, and the bottom are data from NHANES, which for those who are not aware, it's sort of a US survey-based data that assesses a variety of different disease states and questions, but this was used to look at viral hepatitis. And you can see here that amongst both populations, there's big gaps in awareness. And even among individuals that have hepatitis B, you can see on the bottom figure that less than 1/3 with hepatitis B were even aware of their infection. And so if you're not aware of your infection, of course you're not going to get follow-up care, and of course you're not going to get treated. So we really have to think in terms of bridging treatments. We have to talk about how do we educate, of course test and vaccinate, but how do we educate and raise awareness at both the patient and the provider level. Next, I'm going to talk a little bit about screening. As many of you know, in the US, there's been a lot of great improvements and evolution in how we approach hepatitis B screening. What were the challenges in implementing screening? Before this universal guideline, it was primarily risk-based, and we know the challenges with risk-based, which includes many factors, including stigma, engaging individuals into care, not just testing, but after you're tested, we have to engage them for follow-up. As I mentioned, knowledge at the level not only of the patient, but also raising awareness at the provider level on who and how we should implement universal hepatitis B screening. This has to go line in line with guidelines, policy, infrastructure, and in California, there's AB 789, which some of you might be aware. It's a policy which basically mandates providers offer voluntary screening for hepatitis B. How does universal screening help reduce some of these barriers? As I mentioned, reduces stigma, simplifies testing approach compared to risk-based. It helps improve and facilitate timely diagnosis and linkage to care, but it has to be linked with vaccination. So testing is not the beginning, or testing is not the end point, it's the beginning. If you diagnose someone with hepatitis B, you have to ensure they're adequately linked to care, and if they're negative, then we should think about vaccination. I'm going to briefly review some of these data that I know many of you are aware of. These are data published by Malika Toy and the Asian Liver Center group that was published a couple years ago that was really the driver for supporting the new guidelines in terms of universal vaccination. This is a Markov model to look at cost effectiveness and sort of the impact of implementing a one-time surface antigen test. You can see here significant improvements, not only improvements in liver-related endpoints and outcomes, but actually depending on what levels of cost you look at, it can be potentially not just cost-effective, but cost savings. And that's what really led to two major improvements in the past couple years. As many of you know, last year, March 2023, there was recommendations to update universal screening with triple marker testing, surface antigen, anti-surface antibody, and anti-core. I'm not going to read the rationale for that because I sort of went over that in some of the previous slides. But that has to go line in line with vaccination. So a year before that, as all of you are also probably aware, in the US there was a recommendation for not universal, but I would say near universal guidelines for vaccinating adults for hepatitis B. As I mentioned, screening and vaccination is just the first step. Expanding screening is moving in the right direction, but it has to be linked with adequate resources and implementation to linkage to care. Challenges remain in how we effectively implement this. And as I mentioned, guidelines are great, policy is great, but we need to have infrastructure, resources, advocacy, and incorporation into EHR, as well as education, to really manifest these into something that can effectively improve the care of patients that we see. What are the implications with gaps and disparities in linkage to care? So screening is great, but if we don't link them to care, I think we've done a disservice. Timely diagnosis and linkage to care is critical to allow timely initiation of antiviral therapy, because as we've heard with the previous three speakers, antiviral therapy can improve outcomes, reduce disease progression, reduce HCC, and reduce long-term liver-related morbidity and mortality. Understanding gaps and disparities can help guide targeted interventions. And I think many of us that spoke earlier agree that a lot of the complications we see in hepatitis B are preventable if we are effectively able to implement screening, diagnosis, and timely treatments. We can really identify a lot of opportunities to mitigate these downstream complications. Another aspect that is important is a lot of these patients are from socio and economically disadvantaged populations. And we know that aside from the gaps we see with hepatitis B, these are populations that already experience major gaps in access to healthcare, and it really compounds the disparities that we see already in these populations, and hence the importance to really focus, of course, on hepatitis B, but also ensuring comprehensive access to care, as I mentioned, with subsequent linkage and treatment. Now we're going to talk a little bit about treatment. I know the question and the task was, how do we navigate the treat-all approach? But first, I want to highlight in the era where we're of guidelines, what are the existing gaps? And then we'll talk about what are the potential challenges in expanding current guidelines. There are several studies that show low rates and gaps in treatment. This is one study I alluded to a little bit earlier. It's a US claims-based data. Not only were there gaps in diagnosis, but you can see here that only 30% of those with known chronic hepatitis B received antiviral therapy. There were several factors associated with higher or lower odds, and we're going to touch on that in some of the subsequent slides as well. This is another study, actually I think 2 different studies that looked at different safety net hospitals in the US. And you can see here both, I'll draw your eyes to the Kaplan-Meier figure on the bottom, as well as the red box on the right. And the key here is even among those that are so-called eligible, there's huge gaps, anywhere from 20 to 30%. And this is just using relatively strict or current criteria that we define treatment eligibility with. One more study that I want to highlight, this was just published last year. These are data from the Hepatitis B Research Network. Pretty diverse, predominantly Asian hepatitis B population, almost 6,000 person-years of follow-up. And you can see that cumulative treatment range at 72 weeks range from about 45 to 50%. So a little bit better, but still, the way you can flip it and say almost half or more than half of these treatment-eligible individuals did not receive antiviral therapy. What are the reasons for these gaps? I think there's no one answer. They're multifactorial and really dependent, I think, on which population that you're serving. Some of the complexities of treatment guidelines may be contributing to it, confusion, how to interpret. We'll talk a little bit about that in some of the subsequent slides. There's also emerging data. I know several people in this room have published on emerging data showing that individuals that don't meet so-called criteria currently, or those that are in the gray zone, still have significant and non-negligible risk of disease progression to HCC. And so as we think and evolve our thought on how to approach treatment, it's important to think beyond current guidelines and think about hepatitis B a little bit differently. Because as some of the other speakers mentioned, if we are serious about achieving the elimination goals of WHO, I think we have a lot of room to go when only 10 to 15% of the chronic Hep B population is currently being treated. Not going to go into a lot of detail because this is something many of you are familiar with. I highlighted select four of the recent guidelines from AASLD, AASLD, EASL, and then most recently in the US there was a group that published the SABA, or Simplified Algorithm to Hepatitis B Treatment, which continues to show this evolving thought with simplifying and expanding hepatitis B treatments. And then those that were at Kyoto earlier this year at AASLD, WHO released the updated guidelines for treatment. And you can see here, there's a continued movement towards lowering thresholds. And I think there's a lot of reasons for that, and we can have a little discussion later. But I think it's the understanding that one, treatment is very safe. Two, that there are risks of having HCC and disease progression, even beyond sort of what we think about. And I think, as Dr. Rowe mentioned a little bit earlier, that the improvements we have with hepatitis B cure regimens, I think will continue to drive these simplification and expansion movements forward. In the next 3 slides, I'm going to briefly review cost-effectiveness studies from 3 countries. Because the question really was, are we there yet with treat-all approach? And I would argue we're not quite there yet, but we're in the right direction. And I want to highlight 3 studies, one from Korea, one from China, and then one US-based study that really tries to continue to push the envelope and explore from a cost-effectiveness standpoint how cost-effective it is to expand chronic hepatitis B treatment. This is one study published not too long ago. This one is from Korea, where it's a cost-effectiveness model that looked at 3 different scenarios in expanding or simplifying hepatitis B treatments. And you can see the different scenarios here, but I would draw you to the last one, scenario 3, which is treating all non-cirrhotic individuals with a viral load of greater than or equal to 2,000. And you can see as you expand treatment, the number of bad outcomes, poor outcomes that are averted continue to increase. And in this study, granted different population, different health policies, but it showed that all of these scenarios were cost effectiveness based on the Korean health policies. This is one study published last year in one of the Lancet articles. This is in China. This is a decision tree Markov state transition model that looked at a lot of different types of scenarios in different thresholds. They took into consideration not just the traditional parameters we looked at, but looked at age groups, when these potential interventions could be implemented, and then different coverage percentages based on their health, their government's health policy. And I would just draw you to I don't have a pointer maybe, but the one of the lines here, when they looked at all these different algorithms, whether it's ALT thresholds, DNA thresholds, when they looked at expanding to treat all surface antigen positive patients, they found that this approach saved the largest number of hepatitis B related complications. Granted, it was associated with more costs, of course, but ultimately, if you look at the long-term impact of this, it became cost-effective in 2050. And what I didn't mention in the slides is that the Chinese guidelines actually published a couple years ago further evolved this and are really recommending treating any detectable DNA in individuals with ALT greater than upper limit. And I think that's probably by far the most progressive approach to treating hepatitis B in the world, I think. Finally, bringing it back home to US, this is a study published last year that, again, tried to look at different scenarios of cost effectiveness and expanding based on status quo, which is what our current approach is. They looked at 3 treat-all scenarios, and based on different cost thresholds. And they found that at an annual cost of $2,000, treating all hepatitis B infections would be highly cost-effective. But look at this, and this is a push for our industry partners. If you lower the cost of all of this down to $750 annually, it becomes even cost savings. So a really big push, not just to expand this, but make this entire cascade cost-effective and cost-saving for our population. So to sum it up, to bring it back, test all, I think we are there. Vaccinate all, I think we're there with an asterisk because it's not quite universal based on the CDC recommendations. Are we there with treat all? I would say almost. I think we're moving in the right direction. There's a lot of data that's gathering and being published to support this, but I think there are challenges. What are the challenges that remain in implementing this? We need alignment of resources, policy, public health, infrastructure, advocacy, and education, just to name a few. It's also important to remember that the barriers that patients face are very unique. So you really have to adapt it to the population that you treat, understand what those barriers are, and really develop interventions that are targeted to those interventions. Testing is important, but linkage to gap care remains and must be addressed in parallel. Passion and enthusiasm toward expanding treatments must be guided by data, and hopefully very soon we'll have more options for hepatitis B cure. Again, this is to remind us that talk is cheap, but the cascade is complex, and really to implement this requires a monumental effort. But I think given the show of force in this room, I think we are looks very promising that we're able to achieve this in the near future. And this is also, again, to really highlight that there's no one-stop shop approach, and really it requires a team effort from all of these players if we are really going to improve hepatitis B care. So take-home points, hopefully all of us have emphasized for you that chronic hepatitis B remains a major cause of morbidity and mortality. The care cascade is complex, and gaps delay treatments, leading to continued disease progression. There have been major improvements. Test all, vaccinate all, but there's a lot of work that remains, and gaps and disparities are major barriers to the WHO for hepatitis elimination. Treat all, we're almost there, but it looks very promising. Thank you.
Thank you, Robert. I'm going to ask our chair, Calvin Pan, to chair the Q&A. Robert, would you have a seat with us and the rest of the speakers?
Just a quick reminder, I'm your SIG chair. Right after this, we'll have a SIG business meeting. I welcome you all to join us to discuss next year's program and the other business.
Just to remind everybody, very short question, one question per person. We just have a few minutes left. Dr. Wu.
Dr. Pan, your presentation is wonderful. Should we do the HBV DNA 7 days before give birth, and to see which group actually really benefited just from the vaccine itself, and the other group, if the virus load is very low, need or higher, need HB?
Let me try to get this question correct. Is your question about what the role of HBV DNA in terms of use HB?
Yes, the quick question is that because your
You mean the
presentation on 12 weeks treatment with the HB, 24 weeks without the HB. My question is that if we do the HBV DNA 1 week before give birth and see what's the DNA level and decide to give the HB or just give vaccine itself?
No, these mothers, they are all high level of HBV DNA, more than 200,000 IU. So when we follow the viral load, I didn't have a chance to show the viral dynamic during the treatment, but they all gradually decrease. The longer the treatment, the better control of viremia. I hope that answers your question.
My question is that, yes, it's longer, the DNA will drop to begin with. That's the reason we treat. The other things is, if we can do the HBV DNA 1 week before give birth, if the DNA is very low, then you don't need to give the HB, only give the vaccine.
Oh, you mean before delivery?
Yes.
Well, it's hard to predict which one would get into below 20,000. But if you treat them long enough, as I show in the data, 90% plus, they can achieve that level.
All right, next question. Mark?
Yeah, thanks, Mark Yanni. The question is for Robert. First of all, congratulations on a nice talk. So I wanted to ask you about this treat-all approach. I mean, I agree with you that I think a treat-all approach definitely will reduce complications of disease, but I'm not sure if it's necessarily cost-effective in all regions of the world. I mean, there is data from Africa as well, where there's a huge burden of disease, where recent cost-effective analysis showed that a treat-all approach actually was more costly than using other means of starting treatment, such as the treat-B approach. And this is largely because of the cost of testing associated with initiating treatment and monitoring persons on treatment. So my question to you is, should this be more of a sort of be based on resources and burden of disease, et cetera, in different parts of the world, or do you really favor pushing a treat-all approach for everywhere?
Yeah, thanks, Mark. I think that's a really important question because resources are important, testing, costs, and I think I agree with you that while conceptually I think treat all is, I favor that, I think it has to be tailored with the population. Risks are different, policies are different, costs, testing, and I think the solution to this is not going to be a uniform solution for all parts of the world, and I think the approach to how we implement treat all is going to be very tailored to individual countries, resources, and how we implement that.
A question for Dr. Wang, Robert. Really nice presentation. Congratulations on that. I'd like to talk about the advocacy for and the awareness of hepatitis B. And despite the fact that we have, from the moment of infection till the moment you die, you have, 7, 8 government terms. So it's a very long chronic disease. These patients are on the low steps of the social ladder. There's no famous people coming out with hepatitis B. But one of the major problems, for instance, in Europe, is the mortality statistics. So people die silently of hepatitis B, and they die of HCC, which comes into the mortality statistics, yet not viral hepatitis. How is that in the US, and could that be changed?
Yeah, I think that's a really good question because it's still a silent killer. And I think as you raise, Dr. Janssen, that if we don't raise awareness about the mortality burden associated with hepatitis B, that you need that to really ignite change. In the US, we still have those challenges. I think that, as some of the data show, hepatitis B is still very much underdiagnosed, probably somewhere between 30–40% maybe are aware of their infection. Hopefully with these testing strategies, I think that will continue to improve diagnostic rates. Mortality data in the US is also very challenging. A lot of it's ICD code based and reporting biases. So I think even here, hepatitis B related mortality as well as Hep B related HCC is probably still very much underdiagnosed and underappreciated.
Thank you.
Next. I'm a little out of my depth as a patient here. I'm a long-term chronic Hep B patient. I contracted it in 1978. About 1990, I was diagnosed with hepatitis delta, which is not being mentioned very much, and I think it should be. I think cures for Hep B will help with Hep delta. So, and last year, I got a new liver. Thanks in part to Dr. Gish's advice. So my question is, now I'm on tenofovir and HBV. The delta seems to be totally gone, if I'm correct. But my question is, should I hold out for a total cure for B, or should I be content with what I'm on now?
Nan-
Anyway,
Nancy, can you take that?
Nancy, I think, is the best.
So congratulations. Your story is very powerful. I think that the answer is both, right? I think that you need to be very thankful that we have the tools to keep your virus silent. Our post-transplant hepatitis B outcomes are excellent, but you should always shoot for the moon. And so as a transplant patient, you will probably be the last person that is enrolled into a clinical trial. So your demographics will be the last to look
I'm
towards
done.
sterilizing cure.
I was in a clinical trial, belonefarnib, for 6 years. I am not doing any more clinical trials.
But I do think that when we have functional and sterilizing cures, they will be broadly applicable to all patients with infection. But right now, we are just glad that we can prevent reinfection.
All right, we have 5 more minutes. Fast question, fast answers. Dr. Schwartz.
Great morning, thank you. I just want to speak up on behalf of children with hepatitis B, and for that matter, hepatitis C. Because it's fine to make recommendations for universal screening, but I noticed that the screening recommendations were for adults, 18 and above, for hepatitis B. And it's very frustrating, as one who has taken care of many children with viral hepatitis, to listen to the recommendations because we have a cure for hepatitis C approved for down to age 3. And the USPSTF did not accept our enthusiasm for screening universally children with hepatitis C. So it's not going to work for children with hepatitis B, I don't think. But in San Diego, at the family health centers, we did have a workaround for hepatitis B that was really cool, we thought. Wasn't my idea, so I don't take credit for it. But we linked country of origin of high prevalence of hepatitis B by EMR to providers to screen for hepatitis B. And we achieved a dramatic increase in the number of hepatitis B positive patients just with that electronic reminder. So there are workarounds. Thank you.
Good job,
So
Kathy.
I'll just make a very quick comment. There is a poster by Natasha Martin and Tatiana Kushner looking at universal cost effectiveness of screening in pediatrics at certain, like with lead testing or marrying it to another time, and it was found to be cost effective. Now, will that change recommendations? I don't know, but there is still interest in universal screening.
Thank you, Marie.
Thank you. My question is to Dr. Pan. Congratulations for your presentation. Your recommendation is to vaccinate all newborns from HBs antigen positive mothers. Why not to vaccinate all newborns, regardless of HBs antigen status of the mother? Like in Spain. In Spain, we vaccinate all newborns.
So your question is, should we vaccinate even they have surface antigen positive?
All newborns. Regardless
All
of
newborns.
all.
Yeah, I don't see a downside of it because many surface antigen positive actually from mothers went through the pre-center. So I would vaccinate. The vaccination doesn't cause any harm, but I see the benefit of protection if they have false positive.
And prevents liver cancer.
Yeah, thank you. Next.
Thanks, Chair. And my question goes to Robert. Sorry. In your previous slides, you have mentioned these. We are almost there for the function for the treat-all, and based on the current treatment options, we only have nuke and interferon for this kind of patient. But if we have more treatment options, we basically we could achieve somehow of a function cure. What's the basic function cure rate you are expecting to achieve a better cost effectiveness in your mind? I mean,
Yeah, I 100% agree. I think that's one of the challenges we have with how to implement treat all, because for the most part, therapies now are lifelong, for the most part. I think that if we have a finite therapy that achieves high levels of functional cure, that's also affordable, that's very important. I think that will move the needle even further to making this cost effective.
Yeah, so the quick question is, what's the function cure rate you are expecting for this kind of function cure therapy?
Sorry, one more time, what's the?
I mean the function cure rate, what you are expecting for, for cost effective?
Yeah. I don't know, I think that's hard to say because I think that also depends on how industry is gonna price these therapies.
Okay.
But I think that we need something at least 40% functional cure to really make a dent in this.
Okay, thank you.
Yeah.
So thank you so much. We are over time. I would like to ask the two persons standing in the microphone, maybe step forward and ask your personal questions here. I would like to thank all the audience for your participation and big applause to all the speakers and a wonderful presentation. Thank you so much, and I wish you could have time to stay for the business meeting for hepatitis B/SIG. Thank you.
Thank you.
Thank you.
So much information just